Good morning. This is Terry Kuti, and I am recording from the U.S. this morning. It's an early morning for me, but I'm so honored today to have two very wonderful guests on the Deep Sea Foundation educational YouTube channel, where we talk about topics related to breast reconstruction and breast cancer. I would like to welcome Dr. Dancey. She is a consultant plastic surgeon trained in the UK. She is a member of the British Association of Aesthetic and Plastic Surgeons and also the British Association of Plastic Reconstructive Aesthetic Surgeons. Welcome, Dr. Dancey.
Hiya.
And I'd also like to welcome her partner and colleague in the UK, Dr. Ruth Waters. Dr. Ruth Waters is also a consultant trained plastic surgeon in the UK and the president-elect of the British Association of Plastic Reconstructive and Aesthetic Surgeons. I'm so honored to have both of you today on the program.
Pleasure to be here.
Yeah, thank you very much. We're honored to.
Yeah. So what I'd like to talk about today, ladies, first of all, to let the viewers know, you are both reconstructive surgeons who do specialize in DIEP flaps and other flaps for breast cancer patients to restore their breast after mastectomy. But what I'd like to focus in today is really your fine work with lymphedema. You have done amazing things. And the question I'd like to just start out with both of you is, as breast cancer patients, I think that lymphedema is a concern and sometimes almost a fear. But if you could help us understand when we should be concerned about it, how it is detected, and then also the treatment that both of you have become so well known for over in the UK. I'll let you take it.
Shall I start off?
Yeah, you speak first, Anne. Yeah.
Okay.
So yeah, I mean, it's very obvious talking to breast cancer patients that a major concern is lymphedema. Mm-hmm. It's a variable thing, and the data shows between 3% and 30% plus develop lymphedema down the line. Mm-hmm. Unfortunately, it's not that you just get it straight away. It can be 10 years down the lines, but by something like a flight that starts the whole thing off. And having lymphedema is miserable. You know, you've got to wear compression garments all the time. People constantly ask you what you've done and if you've hurt yourself. And it's so restrictive in what you do, even preparing vegetables, washing your hands. It becomes a whole process where you try and do your wet tasks and your dry tasks together. So, you know, there's no two ways about it. To be in a situation where you don't have to have that is preference for everybody. Now, we've developed our practice. I initially started doing it in Ghent, where I trained to do the DIEPs, and they were doing it over there. And then brought it back to England, and Ruth and I worked on it together. The first case we did, we almost forgot we'd done it. We saw her for her DIEP to see how she was going, and she said, "Forget the DIEP." She said, "Look at my arm," and it was down to normal. You know, we were just overwhelmed by it because it didn't make sense. You know, how could you take some lymph nodes based on a blood supply and plumb them in like you would do a DIEP? And then them just randomly start to work and restore all those lymphatics which have been cut off. But that's what it seems to do. And we think that it's a two-part process. The first is releasing all that scar tissue that's formed under the arm when the lymph nodes were taken. And that's an obstruction to any flow of lymphatics which might still be going on. And you could do lots of things to release that, but unless you put vascularized tissue with a good blood supply in that gap, it will just reform again. So that's the first part. And then the second part is what the lymph nodes themselves add. And scans have shown that essentially they start releasing all these growth factors, encouraging new lymphatics to grow, but also old ones to open up. And the scan within 3 months is lighting up like a Christmas tree with the lymphatics working. It's unbelievable from where it was completely black before. Now, there was a lot of skepticism about it from colleagues from lymphedema nurses to begin with, but now you can't argue with the evidence, is it works. You know, we may not know the exact reasons and how, but it's a learning curve, as most breast cancer treatment is, to be honest with you. And now we've got a sizable practice, probably one of the biggest in doing lymph node transfers. And Ruth and I work together on them. We've always done that. It halves the operating time because I can harvest the nodes while she prepares the vessels, or vice versa. And you've got 2 consultant minds on it. If there's a problem, you know, what would you want more than 2 consultants? So we can provide 24/7 care, because if I'm on holiday, Ruth's there. And we've been managing it like that for some time, and I'm really pleased with the results. You know, I can't even think of a patient that hasn't had some benefit. Many of them just don't need to wear compression anymore and get discharged from the lymphedema clinics. We did debate for a while about should we be doing this prophylactically to stop patients worrying about it. And we've got an open mind, but to our mind, it's best to have developed it first, because there's no point going through an operation when he may not need it if you don't ever get lymphedema. And certainly there is a proportion of patients who just won't, and it's a miracle how you can remove all those lymph nodes and they don't have it. But, you know, Ruth and I are very much aware of the psychology behind it and how stressful it is. And I work very closely with my clinical psychologist who talks to patients about their fears, because most women tend to bottle things up and hide it from their family. But they need to be able to talk to somebody in a neutral environment who's not going to judge them in any way.
Yeah, I noticed that you guys have a coordinated care team, which I think is so important, and you're educating patients so well.
Yeah, well, I think it's important they have all the information, because, you know, how can you make an informed choice unless you know what is available and what isn't? And sometimes patients say, okay, well, I know about it now. I'm going to see how I get on with my lymphedema nurses in the interim, which is a very sensible way of doing it. And when I reach that point that, you know, it's not managing it, it's getting worse, that's when I make my decision. And obviously, the sooner you do it, in some ways, the better, because the lymphatics are still fresh. They haven't fibrosed. Although we have treated a patient who had the surgery 30 years ago, and her life was utterly miserable. And then she read an article that one of my patients had written in the Daily Mail in England, and I've had so many patients from that article. They happen to see it in their hairdressers, or, you know, because it's done the works.
Dr. Waters, when patients, you know, after surgery, they have different sensations in the arm, in the axillary nodes, under the armpit. What should they be looking for, you know, what that would be concerning? And then what are next steps for them? I know there's an assessment process.
Okay, so, you know, the typical thing that we all see with lymphedema after breast cancer is a swollen arm. But obviously there's a development of that swelling, and as Anne says, it may not be there for years. It's not something that necessarily appears immediately after your cancer surgery or your radiotherapy. So what a lot of women notice in the first instance is that their rings are beginning to get tight and they can't get them off their fingers. So that's a very common first symptom. And in fact, that patient that Anne was describing, I remember her very well, because it was about 12 years ago that we started doing this. And Anne had, as she said, had been to Ghent and with Professor Blondeel, who was a pioneer in this field and in the DIEP flaps, obviously, as well. And so she said, oh, look, I really think we should try this. And we had a patient that was going to have a DIEP flap anyway and had lymphedema. And I thought, well, I didn't really believe in it at that point, because as Anne said, why would just putting those lymph nodes there, why would they suddenly start working? But we did it for her because you can take the lymph nodes together with the DIEP flap. So it doesn't add a great deal to the length of the surgery that you're doing, or the problems associated with it. So we did it for her, and when we went to see her on the day that she was about to be discharged, she was actually crying, and I thought, oh my goodness, what's gone wrong? There's something amiss here. And I said, oh, are you all right? You're set to go home. And she said, no, it's just that for the first time in years, I can get my wedding ring back on. Oh. And it was just, so it was so moving, because it seems such a small thing, but these things are so important in your life. So that's why I always think of that, being a first symptom of lymphedema is that your rings suddenly get tight or don't fit. And obviously then as it progresses, it can affect part of your arm or all of it. And as time goes on, and especially if it's not treated, it just tends to be progressive, and the arm gets heavier and heavier and bigger, and much more difficult to deal with. So in terms of what we're offering with our surgery, we're replacing lymph nodes that have been removed in the cancer surgery. We're replacing them with lymph nodes from the groin that would normally be draining the abdominal wall. So when we take them with the DIEP flap, that's fine, because that's what they're draining anyway. So that's anatomically right. And we take very, very great care not to take lymph nodes that are draining the leg, because obviously we don't want to create a problem there. So then you tuck up the lymph nodes into the space where they should be in the armpit. And the whole flap and the lymph nodes are revascularized when we join up the vessels. Mm-hmm. And now I think about it, I think, well, why would you be surprised that this works? Because when you do any surgery, and say you join two edges of a wound together, or if you put a skin graft on, within a week you develop blood vessels across that joint. That's just a natural thing that your body does to repair itself. And so obviously it follows that if you do that, then lymphatics will join up too. And so that we believe that's what's happening with the little lymph nodes that we put there. And that there is evidence, you can show that on lymphangiograms and things, that it actually is happening. So that's why it works. And I think the other important thing for women to know is that if you've already had your deep reconstruction and then get lymphedema, it's still not irretrievable, because we can just move the lymph nodes on their own. You can just take the lymph nodes with their own blood vessels, and then find little veins and arteries up in the armpit that you can join them onto. So even if you've already had your breast reconstruction, it's not too late to have the lymph node surgery if you later develop lymphedema. And again, that's one of the reasons why we don't do it prophylactically, because we know, it's never too late. We can always do it if you do get a problem. That is
really good information right there. I'm kind of visualizing myself in, as you call it in the UK, in the theater, correct?
Yeah.
You refer to it as the OR here. I can visualize both of you in the OR, in the theater. When you see that lymphatic flow, you must get a little bit of a tingle and happiness when you see those, not only the perforators, but that lymphatic flow that, as you said, Dr. Dancey, I love your word, replumbed it, because that's basically what you're doing to the viewers. It must give you both a little bit of a charge to see that.
You'd laugh if you actually saw us. We do a rain dance to pray for the flap to flow, and then there's lots of hilarity when it actually works, and it's a huge relief, to see them start pumping up and then just bleeding a little bit, which is actually what you like to see in plastics, because it means it's all working. And we're so superstitious, like we won't let the microscope be moved more than a metre away from the operating table, just in case we have to go back. And honestly, there's a huge paranoia about it. but it's quite fun, and all plastic surgeons in England all have kind of this same relief as soon as everything's working, because you've just invested quite a lot of time in it, and it means everything to this patient that works. We haven't had a case thus far, okay, touch wood, but I can't see any, where we haven't got it to work. But Ruth's brilliant at the tiny micro, because we're talking small vessels here. You know, this is what we call super microsurgery, and it's not easy. You know, we're using very fine threads, more than you would do in a DIEP in some cases.
Wow, that's amazing. Yeah, and sometimes I tell patients the threads that you're using, they're really as fine or finer than a hair filament, right?
Yeah, they are. I mean, if you lose it, you don't stand a chance in hell of ever finding it. You know, it's really hard because they just can't be seen very well with the naked eye. And actually, they won't even show up on a scan, because normally if we lose something with a bit of metal in it, the first thing we do is an X-ray. They don't show up. They're so fine. You know, we're pretty good at finding it if we lose it, because it hasn't ever pinged very far because we're in such a small field. But when you lose it, you're like, I can't believe, where has that gone? And sometimes they just shoot off, you know, blown when you're talking or something ridiculous.
Wow. So once you do the connection of the lymphatics, whether it's in a DIEP or, you know, as you said, Dr. Waters, you can do it later down the road after breast reconstruction. What is your follow-up with patients then? What assessment and follow-up do you do with patients then? And what is there any physiotherapy, physical therapy that is done afterwards? What would that be?
Yeah, it's very important that women that are going to have this are under the care of a lymphedema nurse. And usually they are, because usually they've been having their lymphedema managed with conservative measures before they come to us. So they all have measurements of the arm done beforehand to see how it is, and there's a record of any other issues they've had as a consequence of the lymphedema. So sometimes they get a thing called cellulitis, which is a serious infection in the arm as a consequence of the lymphedema, which you get just from a minor injury if you have lymphedema. So all of those things will have been recorded by the lymphedema nurses before the surgery. And then afterwards, they have the usual physio that they would have if they've just had a deep flap. But also that very specialised care from the lymphedema nurses. And again, it's they who do all the measurements for us and record symptoms and everything. And generally, what we expect to see is over a period of months, maybe a year, that the symptoms resolve. We don't expect necessarily that it's going to resolve completely. A lot of how well it does will depend on the extent of the lymphedema beforehand and how long they've had it for. Because after years of having lymphedema, what happens is that you start laying down very dense fat in the arm. So not all of the swelling is just the lymphedema, i.e. the fluid in the tissues of the arm. So if that is the case, if they have had a chronic lymphedema and some of that residual swelling is there, it's probably due to that fatty change in the arm. And if that is the case, then the next stage would be to consider liposuction to remove that fat. So that is something that we have had to do, not frequently, but every now and then you get to that situation where you think, right, it's improved, but it's not got as good as we'd like it to be. And you do another scan and you can see the difference between lymphedema and fatty change. And at that point, you would consider doing some liposuction. The downside to the liposuction is that you then do need to wear a garment again to maintain the reduction in swelling that you get from that. But so we explain all these things, and it's a choice that the women can make as to whether they go ahead with that.
Yeah. You know, to both of you, this has been truly a fascinating conversation, and I hope that it brings hope and also the needed education for this, because Dr. Dancey, you mentioned earlier that it's really a topic that many women don't want to discuss.
Yeah.
At least, and so to have both of you not only treating it, but to address the fact that they have someone there for women to talk to about this. Oftentimes, and correct me if I'm wrong, I feel that lymphedema, you know, I think some may think of it as a disease, but it's really a condition. And because it's a condition, it can happen, like you said, many years or months after surgery, but something that really can be treated in many good ways, but needs to be, you know, women need to be able to be educated and to talk about it. And so I really appreciate both of you spending the time today to educate and to talk about it, because, you know, we can't all come to Dr. Dancey and Dr. Waters. Many people are very fortunate to be able to, but what we hope to do in these videos is to educate so that other women, you know, when they go to their consult, they have the words and the education to discuss it. So I really appreciate both of you being here today.
It's an absolute pleasure. Thank you so much. And, you know, it's lovely to be able to help in some way. A huge topic that causes so much anxiety, understandably, and just to do a little bit about we sort of addressing those concerns and worries.
Yeah, thank you, Terry, for this opportunity. It's lovely to see you too.
Well, be sure to comment or ask any questions after the video is published. We always appreciate any likes, and let us know if there are other topics that we can cover here at Deep Sea Foundation. Ladies, thank you both for joining us today. It's been a pleasure.
Thank you.